Well, welcome to the podcast. I'm Marcy Markusa, your host. And if you're new to the podcast, everything on This is Manitoba is about you living in Manitoba in your life. Now, one of the things we take for granted here is access to healthcare. Today's question around our podcast, so I always like to look at a question in depth, is looking specifically at who is not getting quick enough access to healthcare in this province. So the question is, what role does the color of your skin play when it comes to the quality of care you receive in Manitoba emergency rooms? It's a big question, and why not? Because the report that seeks to answer that question is big as well. It has been looked at by Shared Health, who's been collecting race-based data from hospitals and medical centers all across our province since 2023. And today we're going to look at some of the findings. Not only that, but we're going to get some reaction to some of the findings from two guests. One who is a leader in our Indigenous community, and the other who has been looking at improving healthcare for Black Canadians and by extension Black Manitobans all across this province and in this country. So those are our guests today, but let's first start with what this report found. So some of the most serious statistics that they found show that Black and Indigenous Manitobans generally spend more time in emergency departments waiting for care. Now, for some context here, white patients, according to the report, in need of serious care, waited just over 8.5 hours at some major Winnipeg hospitals. In comparison, Black Manitobans in need of serious care, just to pull out one stat here for you, spent about 12 hours in the ER. So 8 hours compared to 12 hours. The first guest on the podcast today is Dr. Barry Lavallee. He's CEO of Keewatinohk Inniniw Minoayawin, which works to improve healthcare for First Nations people all across northern Manitoba. He says, however, that this new report does not go deep enough. Well, thank you so much for joining us via Zoom.
Thank you, and good morning.
What are your concerns about the methodology and how they looked at this?
Well, I mean, let me say it first. What isn't apparent with Marcia's release is the number of years that it actually took them to get there. And we need to acknowledge that on Ongomiswin, as well as Shared Health, that this was not a simple step to try and isolate indicators of racism within that system. That must be said in the beginning. Now, I work as CEO for Keewatinohk Inniniw Minoayawin. I get the cases from all over the north about people who are harmed by stereotyping, meaning that they are harmed physically, psychologically, spiritually by racism that's specific and unique to First Nations people. And in fact, we have death by racism. So, at its first glance, when you look at the data set, that took a long time to get there. But it doesn't, at this point in time, speak to the intensity, the veracity, and the violence that First Nations people can encounter in attempting to seek access to care.
Does it take away because it's, that it looks at all groups? Because I understand one of your criticisms is that sort of that the experience of Indigenous people do you believe that in all studies they should always be separated out because of the long history and, as you said, the complicated nature?
Yeah. I think racism as a general pattern of behavior certainly applies to non-white people, but its level also can apply to LGBTQ community, to people who are disabled, and then experiences I imagine, by women, all colors, can be oppressed within that system. But on a gradient of what really happens, First Nations specific racism is much more operant. And I'll explain why. We did a study in BC where we examined 30 episodes, 30,000 episodes actually of stereotyping in a data set, and worked with that. And we found that basically a First Nations person looking as First Nations and or having identifiers as First Nations, when they enter a healthcare system, they enter it in stereotype. And it's very important for people to understand that, meaning that one of the more common stereotypes is that Indigenous or First Nations people drink a lot, okay? Or First Nations people don't care for their health, et cetera, et cetera, et cetera. Now, that is operant within the data, but you can't see it yet. And I think, yeah, go ahead.
I was just going to interject and say, so your bigger concern here is not pushing back that, because some people might say that including the full look at the picture amplifies what's happening with Black patients in our healthcare system. But your view is that overall it might invalidate, I think has been your language, Indigenous experiences. So you're not saying that we shouldn't be looking at the experience of Black patients in the system, but you feel like that it's just much more complex for Indigenous experiences, and it should be, do you think it should be always separated out?
It should always be separated out.
Okay.
Now, the experience of other racialized group, of course, is really important. But what we know and see on the ground is that Indigenous specific racism, when acted on through stereotyping and other mechanisms, can kill and does kill First Nations patients.
So let's talk about 2018, because with all due respect to any of the results in any study that we've done, I mean, Brian Sinclair died 17 years ago now in a Winnipeg ER waiting for care. At that time, one of the calls to action was having better training and education for people in the medical system, anti-racism education. This morning, we have yet another report that says the exact same thing. What needs to happen to move us past studying the problem and getting to solutions in your view?
That's an excellent answer. So the work that Marcia's doing and her teams is really important for the future. And as we align that with actually narratives of violence, we can actually see better how the system actually acts, sometimes inadvertently, sometimes consciously, to minimize, diminish, and demean the experience of First Nations people seeking care. Okay, that's a fact. But racism for First Nations people differs than other people of color, because First Nations people are tied in Canada to the land, whereas settlers who come who are of color, they're not tied to the land. So that the economic analysis around racialization is true, and it is incredibly violent for First Nations people. And we see that in systems like healthcare systems that are made to help all of us.
I understand that in reports, you feel that keeping it, as journalists, we like to focus on numbers, wait times, those tangible things. But you actually think that if we're going to change this, instead of having education systems based on numbers and data, we should have more stories of people in reports like this. Why do you think that?
Well, I mean, one of the things, and this is going to sound like a little bit maybe unusual, is that the racism for First Nations people really, I believe, is centered on hatred of First Nations people. Now, people won't like what I'm saying, but it's true. So we've always tried to give a picture to medical providers, nursing providers, researchers, that First Nations people are human. It sounds crazy, but the way we behave towards First Nations people is as if they're not human. So one author calls it the frontier status. Anything can happen at frontier status. There's no law, there's no medicine, there's nothing there. And that's really the kind of covering that we see when a First Nations person can identify in a system. And the data, I'm not going to critique the data because they're the experts. But the data will not tell you yet the depth of what happens in an emergency room when you're sick and people are accusing you of being intoxicated. Brian Sinclair, and I was one of the leads on that particular file, he died by stereotyping. There were really, when we looked, there were no nurses or doctors who committed anything. It was at the beginning in triaging. They didn't even acknowledge his pain or whatever he needed because he wasn't on the sheet for the triage nurse to see. Mm-hmm. So that's how racism looks. It's through stereotyping of First Nations people.
Dr. Lavallee, thank you very much for being with us today.
Yeah. Okay, have a good day.
You
Bye-bye.
as well. Bye-bye. That's Dr. Barry Lavallee. He's the CEO of Keewatinohk Inniniw Minoayawin. You can read more in the story, by the way, and find the full report if you're interested at cbc.ca/Manitoba. Now, as I mentioned at the beginning of the podcast, we were going to look at two perspectives from two people who are have looked at the stats in this report very closely. So next on the pod, we have Sume Ndumbe Eyoh, who's the director of Black Health Education Collaborative. This is a group of educators and doctors that have come together, and they're dedicated to improving healthcare for Black Canadians across the country. Now, as someone who's been immersed in the work for years, she says the findings of the report don't surprise her at all that Black Canadians are waiting longer than others. And here's my conversation with her about the troubling statistics. Thanks so much for being with us to weigh in on this.
Good morning. Thanks for having me.
So why are you not surprised by what I've just said? That people who are Black and waiting in our waiting rooms, or perhaps waiting longer, and in some cases maybe facing racism.
So the reason I'm not surprised is that when we do this kind of research across a whole host of health issues, in different settings, be it in the emergency room, in primary care, pretty much everywhere where Black folks are interacting with the healthcare system, we tend to see poor outcomes. And usually this is because of a failing of the system to actually respond to the needs of Black community. We know that across the healthcare system, anti-Black racism remains a very profound reality.
What's the cause of it when you look across the country at the individual cases where this has been happening?
Well, I think it's important for us to look beyond individual cases because, of course, we can cite examples of individuals. But what this report is showing us is that it is beyond one individual practitioner behaving badly. I think that's important. It is really our health system failing us. And what that looks like is we see racial discrimination from healthcare providers. In our own research, we found that our Black folks report that healthcare providers actively minimize their symptoms. And this report actually shows that, right? So you come into the healthcare system and your concerns are not taken seriously. So oftentimes people have to go back multiple times to actually get the care they need and really insist on that. There's a lot of stereotyping which happens in terms of folks being labeled as just being, seeking medication, drug seeking. So we see these really harmful stereotypes which impact care. I think, again, if we think about our healthcare system, are we training our healthcare providers across the spectrum to deliver culturally affirming care? The unfortunate answer is no, which is really some of those gaps which we at the Black Health Education Collaborative are trying to close.
What's at stake if what you've just said there is part of this is if somebody goes and they're not seen or they're ignored, they don't go back. So what is at stake here for Black Canadians if we don't improve the system to meet their needs and to have them feel like they are seen when they are there to be seen for their health needs?
I think simply put, it's lives. Like, we're talking about people, like actual human beings. We're talking about lives, right? And what we know is that when people don't go back, you often you're delaying care. So already if you're presented at emergency room, it means that you are usually in a dire situation, and this report confirms that. And so then if folks come in and leave because they're not being seen on time, then they're staying at home and their healthcare condition is worsened, right? So then down the line, you have people who again present with more severe health concerns, which again, the literature and the research across the spectrum of issues and settings confirms that, because Black folks are more likely to be underdiagnosed and diagnosed with a lot of illnesses at a later stage, right, which makes treatment a lot more challenging and recovery a lot more difficult.
What stereotypes about Black people do you hope that this research that we're looking at challenges? You've mentioned, you've mentioned one of them, but I'm wondering what else shows up when you see the problem systemically.
Yeah. So I think the first thing I want folks in the health system to really understand is that Black communities across this country, across the world, we care about our health, right? We take our health very seriously. And so healthcare providers should understand that when Black folks are coming into the emergency room or into any other setting, it's because we take our health seriously like everyone else in this country. And so that's one thing. I think the idea that people are making things up and it's all in your head, or that Black folks don't feel pain, I think the report also speaks to that, right? Sometimes there's been lots of research which shows that even for the same conditions, Black folks are more likely to be given lower pain scores, which then impacts the kind of care you receive. You're not treated, your issue's not treated with the same level of urgency. So I think really undoing those stereotypes, and importantly, understanding where those stereotypes come from. the stereotypes which we're confronted with in the healthcare system are not new. They're really stereotypes which have been developed and grown over centuries. And so we need to understand those histories and start to actively let them go. As healthcare providers and practitioners, there is a deep attachment to the things which we do. We see some of this attachment in medical diagnostic procedures, which have been proven to be actively racist, but which continue to be used, and bias in medical algorithms. So things like, kidney function scores, which is no longer used. Those criteria are no longer used in the States, but we're still doing that in the Canadian context. So I think what folks need to do is unlearn those stereotypes and actively replace them with practices which will improve the health of Black communities. So really with culturally affirming care, which means listening to people properly when they come, understanding the history which Black communities face, including things like, the history of medical experimentation, which communities continue to live with, which has created a huge distrust. So the fact that in spite of the distrust which exists, Black folks are still presented in the healthcare system. Again, I think emphasizes my earlier point that we do care about our health. So even though the healthcare system continues to fail us, we continue to show up. And so it's way beyond time actually, that the healthcare system in Manitoba and across the country do better.
Can you elaborate on what you just said there about kidney care and a change that has happened in the States that you say is overdue to happen here?
Yes. So in different medical diagnosis tests, the different ways in which scores are calculated, and with the kidney function test over decades, and there's been this additional number attached to Black people, right? So this is really based on the idea that somehow Black bodies are different from white bodies and white bodies are different from brown bodies, which we know it's not true. There's no biological basis for race. And this addition to the scores do is that Black folks are often given lower scores, which mean that their kidney disease appears to be less severe. And it goes back to my point around, if your kidney disease appears to be less severe, then you're less likely to get the level of treatment you need, which means, again, we see delayed intervention.
So what have they changed in the States that we're still doing here around that?
Yeah, so they've removed that, that race adjustment criteria, so that your score and my score are the same if we have the same level of kidney function.
And do we still have that across Canada? That hasn't changed anywhere in this country?
That has not changed in the Canadian context. And that's just one of many examples.
Earlier this week in a press conference about the report that started our conversation, or led to us speaking this morning, Dr. Marcia Anderson, who led the research, recommended that healthcare providers use the Black Health Primer. It's a module that was developed by Black Health Education Collaborative. Can you give us a bit of insight into what that primer is?
Yeah, so the Black Health Primer is a resource which we launched a year ago. It's available in English and French. And what it does is it's designed to close the profound gaps which we know exist in medical education and public health education and nursing education, pretty much across health education. And so it provides foundational knowledge to healthcare providers, to practitioners, to students on the history of anti-Black racism in this country, how it impacts our health, how it shows up in the healthcare system, how it impacts health outcomes. The course also talks about the ways in which anti-Black racism shows up in other systems, because we know that our health is influenced by way more than what happens in healthcare. It's influenced by where we live, where we work, where we play, where we worship. And so it talks about the ways in which different systems, things like the criminal justice system, policing, child welfare, intersect with the health of Black communities. The course also talks about the ways in which anti-Black racism shows up in things like education, right? So really making the links between our health and where we live, work, and play. I think for me, importantly, the course talks about what can we do as an individual practitioner? What can you do to change how you practice? And it also speaks to the responsibility and the accountability needed in the healthcare system to improve the kind of care which is delivered to Black communities.
There is some criticism of this report. We had it on the show yesterday, that aspect of this. We had someone sharing concerns that it invalidates the Indigenous experience by including other communities, not because the other communities don't need the research and attention, but because the Indigenous experience is, our guest was saying, more complex and perhaps longer history, maybe different research done on it. So just wanting that to be separated out. I'm wondering what your response is to that.
Yeah. Well, I think Indigenous health leaders get to decide how they want Indigenous data and Indigenous information to be presented. Now, what I'll say is that I do believe strongly that the healthcare system has a responsibility to address the concerns of Indigenous people, of Black communities, and in terms of our history, if we think about our history as Black people on this land, there's been Black presence in Canada and Turtle Island for a very long time. A lot of that linked to the transatlantic slave trade, and so when Black folks make demands for our health, we don't do that to invalidate the concerns Indigenous peoples do. In our own work at BHAC, we actively work with Indigenous colleagues and recognizing, and you'll actually see that in the Black Health Primer, recognizing the ways in which colonialism continues to impact Indigenous peoples, and also speaking to the ways in which Black and Indigenous peoples have been in solidarity for centuries. Because if we're thinking about what is the problem here, which we're trying to address, the ways in which systemic racism shows up in our society, the ways in which white supremacy continues to impact care, and of course that impacts Black communities in very distinct ways, and that will impact Indigenous peoples also in very distinct ways. And so I do think that the healthcare system has a responsibility to show up for Black communities, and that there's space and actually enough resources for the healthcare system to do that. I think there's a lot of sometimes in the healthcare system when communities make demands of our government, of our healthcare system, we get met with this idea that there's not enough resources to go around. And I think we need to actively challenge that because our government, our healthcare system has a responsibility to live up to what they're required to do. And that includes paying attention to Black communities.
Thank you very much for being with us this morning. I'm sure it won't be the last time that we speak. And I really appreciate having you on CBC.
Thank you so much for having me.
So that was my conversation with Sume Ndumbe Eyoh, who's the director of Black Health Education Collaborative, which, as I also mentioned, I'll just say it again, is a group of educators and doctors dedicated to improving healthcare for Black Canadians. Now, I'm fully aware that you might be leaning in as a Manitoban to the podcast. This is Manitoba Today, but you also might be tuning in from across the country. We'd invite you to weigh in. Maybe you're listening to some of our challenges here in our healthcare system, in our emergency departments and rooms, about wait times, about unequal access to care, and you're thinking, well, we have a solution for that in our province. We would love to hear from you. You can write to the podcast under our CBC Radio email, which is radio893@cbc.ca. And thanks for being here with us today. And if you want to like, subscribe, and share, we'd love to keep you along for another episode.